Hi, good morning. So we're here today to talk about psychotropic medications and some of the important things that you should know about their prescribing and monitoring when you see patients taking them in the hospital, particularly if the patients are physically unwell or really off their usual baseline. So my name's Emma Phillips. I'm one of the liaison psychiatrists. I work across Gloucestershire and Cheltenham Hospitals, and here with me today.
My name's Izzy Dixon. I'm one of the Mental Health Clinical Pharmacists. So I work primarily at Wootton Lawn and Charlton Lane hospitals, but I also work over at GRH occasionally as well. And the last couple of years I've worked at GRH primarily. So I hope to think I can be helpful.
So I suppose, Izzy, the first thing that we ought to think about is what are psychotropic medications?
Yeah, so I think the way I always think about it is essentially if you think a medication is going to affect your mood, your perception, something like that, how you're feeling, your brain in general, that's probably a psychotropic medication. Mm-hmm. So there are lots and lots of different types. Generally, you'll see them prescribed by a psychiatrist like yourself. There are obviously the sorts of illegal ones as well, but we're not going to go into those today. But the main ones that we're going to see are going to be things like antipsychotics, antidepressants and things like that. But it's really important to actually be aware there are some medications that originally were psychotropic medications, things like olanzapine, that are now used for physical health conditions as well. So olanzapine is now used for nausea, duloxetine for pain, things like that. Mm-hmm. So just because they're on a psychotropic medication doesn't mean it's a patient with any mental health conditions.
Yeah, so you might see them prescribed by a whole variety of different teams like oncology or
absolutely.
Particularly the pain team, like you say.
Yeah.
Okay.
Do you want to give us, some examples?
Well, let's start with some of the antipsychotics, shall we? I love a nice list of antipsychotics. So with the antipsychotics, I think it's quite helpful to think about splitting them into two groups. Mm-hmm. And those groups have got a whole variety of names. So sometimes they're called typical and atypical, or sometimes they're called first generation, second generation. But on the whole, the sort of older, typical first generation ones that we might see in the hospital might be things like haloperidol, fluclopenthixol, zuclopenthixol, and some of the kind of second generation ones you might be a bit more familiar with, like olanzapine, quetiapine, risperidone, or perhaps aripiprazole. So we already touched a bit on why patients might be taking antipsychotic medications, but perhaps should we expand on that a bit?
Yeah, absolutely. And like we mentioned before, touched on slightly, there are a whole variety of reasons someone might be taking an antipsychotic medication. So it might be someone that's in hospital for a physical health reason that's developed delirium or agitation. So most commonly, I think we usually use like haloperidol in those situations here. Mm-hmm. It might be somebody that's come in on an antipsychotic that was in the community. It might be that it's in combination with another medication, so for depression or bipolar if it's with like a mood stabilizer, or it might be for a patient with something like psychosis and schizophrenia. But like we mentioned before, it can also be treating physical health things. It might not be for psychosis. Just because someone's taking an antipsychotic, they may not be now and may never ever have been psychotic. So it's, I think, a misconception.
Yeah, I think that's something that's really important to remember, actually, because I think people can get quite hung up on it. Remember, we had a patient a while back where the team got really worried about them being on an antipsychotic and what their behaviour might be, and it turned out they'd actually prescribed it themselves only a few weeks before, but nobody had read the notes. So you do have to be really careful about that.
Definitely.
I think just thinking about sort of prescriptions that we might use in the hospital, I just wanted to touch a bit on the haloperidol for delirium. That obviously a whole variety of different antipsychotics that you might use, and haloperidol is quite an old-fashioned one, often with quite a few side effects. So you might wonder why we use it for delirium, and the main reason is that it's because it's in the NICE guidance and licensed, and so in general it's better to choose a medication that is sort of evidence-based for delirium rather than any of the others. We'll talk a bit about some of the side effects of some of them, but haloperidol also it's got a few side effects, but it only hits a few receptors really compared with some of the other antipsychotics, so it tends not to have some of those sort of secondary side effects that some of the newer ones have. And we use very, very low doses, so sometimes we get calls from people kind of asking about monitoring or worrying about the haloperidol, and I think in general you're not using the haloperidol to manage the actual delirium. There's no evidence base for any medication for delirium, sadly, but to manage the sort of agitation and things like that. And so if you're needing it for that, then sometimes monitoring's not possible. Obviously, if you could get an ECG or something, that might be helpful, and we'll come on to why that might be. But so I suppose just touching on that haloperidol there, it's a very commonly used one in the hospital.
Yes, absolutely.
Yeah. So if we find a patient taking an antipsychotic in the hospital, I suppose thinking about what the pharmacy team would normally do in their meds reconciliation, or what should the junior doctors do? What would be kind of helpful?
Yeah, absolutely. So I think the first thing, as with any medication, go back to your basics. So is it the correct drug? You mentioned a couple before that they can sound really similar and get mixed up really easily, things like Zuclopenthixol and Flupentixol. It also gets really confusing if we start using brand names like Clopixol, which one's that, and all that sort of thing. So is it the right drug? Is it the right dose? Or things like timings, are they taking it at the right time? Obviously, Dewey is really useful for that. So there is now a third tab on Dewey. So your first tab for the medications, you're looking at active GP repeat prescriptions. So most of the time it would be physical health meds, but there will also be, the psychiatric medications if it's appropriate for the GP to be prescribing.
Yeah.
There's a second tab with discontinued repeat, so that can be helpful if you're looking at if doses have changed recently or something's been stopped. But the third tab that is becoming more and more used now is like a medication. It's like it's meds prescribed elsewhere, I think it's labelled as. So if the GP has been told that one of the, say, recovery teams, so the community teams with the mental health are prescribing for a patient, they'll often put it on their system just for information, for drug interactions and things like that they can check when they're prescribing antibiotics or something, say. So Dewey's really helpful. Something that we definitely push for in pharmacy is get a second source, like get something that corroborates that if you can. So ask the patient. The patient often is one of the best sources. You can just ask them, what time do you take your tablet? How many times a day? How many tablets do you take? And particularly like if they've come in with a physical health condition and their mental health is stable, a lot of these patients are very adamant, this is what keeps me well, this is what I need, and they are really, really great sources.
Yes, absolutely. Yeah.
But otherwise, a quick call to either yourselves in the liaison team or us at Mental Health Pharmacy. We can have a look on other sources if they're under sort of secondary care mental health and get a double check for that. I think other things to be aware of, like we sort of briefly touched upon, drug interactions. Some of the really important ones, a lot of psychiatric medications, unfortunately, just because of how they work, like you said, there's a lot of receptors involved. They are not clean drugs by any means.
No.
So checking things or getting a pharmacist to check for you. Drug interactions, QTC prolongation particularly.
Yes.
If you're considering amending or stopping, please don't do so without contacting.
No.
It's about, like yourselves in the liaison team.
Get in touch with us, definitely.
Yeah. If there is sort of particularly complex physical health or anything that you're treating and you need to use certain antibiotics, but the BNF says there's an interaction, have a chat with the pharmacy team, have a chat with the liaison team, and just check base and touch in and see if they've got any advice.
Yeah, I think that's really important. I think people often are a little bit reluctant to ring us if they think that they're not making a referral, but we're always happy to give advice. Lots of our team are nursing team who don't prescribe, or social workers, so sometimes you might not always get an immediate answer, but you can always leave a message, and there's doctors around always during the week who can get back to you, so that's really important. I was thinking, you mentioned sort of interactions with for instance, antibiotics and things like that, and I was thinking about QT prolongation. I think there are quite a lot of sort of common things that are prescribed in the hospital that do that as well. So although most of the psychotropic medications are kind of culprits, I think we sometimes forget about some of the other things that we prescribe, and it's often the interaction, isn't it, that causes the trouble.
Absolutely.
So particularly some of the macrolide or quinolone antibiotics, cotrimoxazole, methadone, some other things that are really quite commonly prescribed. And so it is always worth kind of just thinking about that and having a chat, isn't it?
Yeah, even things like, I think one of the most common interventions we used to make was with antiemetics. So some prolong QT and some don't. If you can use one of the other ones and it's a PRN, then obviously that's a preferable option.
Then that's much better.
Yeah.
And I think thinking about QTC, I mean, make sure your patient has had an ECG, that you've had a look at the ECG, that you've thought about QT, and particularly if you're uncertain, you might get a senior colleague to look at it, or have a look on the online formulas to make sure that the machine-read QTC is accurate, because if your patient's particularly bradycardic or tachycardic, it's worth checking that.
Yeah, absolutely. And we definitely refer to you guys on that one.
Yes,
ECGs are just magical mysticals to me. So we briefly sort of talked about QT prolongation and that they're dirty medications, but what other side effects do you typically see with antipsychotics?
Like you said, they're quite sort of dirty drugs pharmacologically. They can often hit quite a few different receptors, and so that can often give them sort of a few and various sort of adverse effects. I think in general we talked a bit about, didn't we, about the first generation ones and the second generation ones, and that's quite a helpful sort of divide in thinking about side effects. So if you're thinking about those first generation older ones, they tend to have very high dopamine affinity, so they block the D2 receptors, and that's how they kind of have their antipsychotic action. But there's D2 receptors in sort of bits of the brain that don't affect the kind of mood and sort of psychosis type pathways. They thinking about sort of Parkinsonian type symptoms, so people can get movement disorders or dystonias, and sort of what we call extrapyramidal side effects. Extrapyramidal side effects are the motor symptoms that don't come through the motor pyramidal tracts, basically. So they go through the basal ganglia, which is the bit that goes wrong in Parkinson's disease, and so it can look a lot like Parkinsonism. So those are the older ones, and they tend to kind of focus more on those sort of motor effects and stiffness and that kind of thing. The newer medications hit a whole load of other different receptors, don't they? So, thinking about kind of cholinergic receptors or histamine receptors, and so those can often have a whole variety of other side effects like urinary retention or constipation, sedation, and then it sort of metabolic effects that the histamine receptors cause, like weight gain. So so they're not very nice drugs and they cause a lot of side effects, but they can also help quite a lot of people.
Absolutely.
So thinking about how we might prescribe them, how might you see a person be prescribed antipsychotics? Because it's, most of the sort of physical health medications just tend to come as tablets, don't they, on the whole, but we tend to see them in a variety of different forms.
Yeah, absolutely. So like with physical health medications, some patients will be on oral tablets, and depending on the drug, that will depend on once a day, twice a day, whatever. It might be modified release or immediate release preparations, so that's something else to look out for, particularly with things like quetiapine. The doses do depend on whether it's immediate or modified release, so something else to keep an eye out for, especially when prescribing on Sunrise, because I know the drop-downs, often the first option is not the option that you may need to pick. But like you mentioned with our patients, because of the nature of their illnesses, sometimes they do struggle to remember to take and keep on top of their regular medications. So we might use depot injections. You'll hear them termed depot or injection, whatever they want to call them. And that's basically like a prolonged release version of what's often an oral medication as well. So often patients will be stabilised on an oral medication and can be transferred over to a depot equivalent. And they can be administered anywhere from every 2 weeks to every 3 months, depending on the drug and the formulation and all of that sort of thing. But it's really, really important that they don't miss those doses just because they're unwell in hospital. So again, confirming with Dewey, yourselves, us in the pharmacy, just check with someone what is it, when's it due, and making sure that doesn't get missed. So making sure it's ordered in enough time and everything is really, really important.
I think for those patients, they're often under community mental health teams as well, and so the patients who are under those teams who are receiving medications regularly might have a care coordinator, who's often a nurse in the mental health community team, and the patients will usually be able to tell you who their care coordinator is and how to get hold of them, and that person's a really helpful resource and may often be the person who gives the depot medication themselves usually. So some patients get them at the GP practices, don't they? But lots of patients receive them from their community team. So that's worth checking. And sometimes the community teams will actually come in and give the depot medication in hospital. So again, if the nursing team on the ward are feeling uncertain or unfamiliar, that's something that could be explored if you need to.
Yeah, absolutely. I think even if the community teams are coming in, making sure that it has been at least prescribed on Sunrise, so there is a record that it was given, is really important. Firstly, to make sure we give it at the right time the next time, but also for things like drug interactions and things.
Absolutely.
We do need to know what's gone on, what's gone in.
So you need some really kind of careful liaison between your hospital and community teams for those kind of things. But so what if we found somebody who seemed to have sort of schizophrenia or bipolar disorder or something in their kind of health record, but you couldn't find any medications that they were prescribed? Why might that be?
Okay, so we sort of briefly mentioned it in the question previously, I suppose, with community teams. So secondary care, community mental health teams often retain prescribing for certain patients, and it might be because their dose is being amended, or it might be because we're in slightly more regular contact with them and they're slightly more sort of unstable at the time for whatever reason. So those medications, if we're retaining the prescribing, aren't going to show up on things like DUI unless the GPs are adding them, and that doesn't always happen. So it may be that there's nothing on the GP record, but either giving a phone to the GP if they're open is a really good way of checking, because they should still be aware if a patient is under secondary services. Otherwise, trying to get hold of whoever the care coordinator is really helpful. But again, yourselves at Liaison and us in pharmacy, we can sort of access those secondary care systems for the mental health teams. So we should either be able to tell you who the care co is, or if not, give you information on, you know, what they're prescribed usually, or when it's due, or if they are on nothing, then if there's a reason they're on nothing as well.
Yes, so I think just trying to find out that bit more information, particularly if things don't seem to match up, is really important, isn't it?
Yeah, I think the most common ones tend to be the depots that we keep hold of in secondary care, but also things that GPs aren't allowed to prescribe, like clozapine. So two that are really, really important and really cannot be missed.
Yes. So I think that brings us nicely onto clozapine, doesn't it? Perhaps if I say a little bit about clozapine. So clozapine is one of the second generation antipsychotics, and we only use it for treatment-resistant schizophrenia. So that's schizophrenia where people have been tried on at least a couple of other antipsychotics and not had any treatment response to them, and they've still been poorly. Clozapine is a really good antipsychotic, but it's one that also hits many, many, many receptors, and as such has multiple different side effects, including some quite dangerous ones. And so for patients to be prescribed clozapine, they have to be registered with a monitoring service, and both the prescriber and the patient have to be registered, don't they?
And the pharmacy as well, actually.
And the pharmacy as well. And the patients who receive it, because the main kind of worrying side effect that we're checking for is agranulocytosis, or a kind of reduction in your bone marrow and white blood cells, so putting people at sort of major risk of infection. So they have to have regular blood monitoring to be prescribed it, and those blood results have to go back to the monitoring service, and they actually won't dispense the clozapine or give it out to you unless you're doing that. I suppose I should also mention we can use clozapine for psychosis in Parkinson's disease, and it's quite a good treatment for that. And we're looking actually locally to try and set up a kind of service where we initiate patients on clozapine for Parkinson's psychosis. So that might be something that you see in the future, but it tends to be much lower doses than those patients that we see for schizophrenia. So thinking about the monitoring service, I don't know if you probably do a lot of work with the monitoring and things, Izzy. I don't know if you can say a bit more.
So you'll hear, so obviously we're calling it clozapine, but patients might call it different things. So in the last sort of 12 to 18 months, we've switched over between brands, and essentially the different brands of clozapine are with different manufacturers, so they're different like monitoring agencies and everything. So you might hear Clozaril thrown around, but the brand that we currently use is called Zapanex, and that's what it's prescribed as on Sunrise. So if you type in clozapine, it may not come up, but it needs to be under Zapanex, which is the brand name, because patients have to be maintained on a single brand. So because we use Zapanex, the monitoring system we use is called ZTAS, and that basically, like you said, so we're doing the regular full blood counts, and depending on how long a patient's been on treatment for, and depending on what their results have been, will depend on how regular that has to be. Something, again, that absolutely cannot be skipped just because they're in a hospital. ZTAS won't allow us, like you said, if you've not had blood test, you will not get your medication. We cannot legally give you any medication until we've had that from ZTAS. So if there's a reason that we can't be having bloods, that needs to be escalated to yourselves really, really quickly. Again, when a patient comes in with clozapine, pharmacy should hopefully have been contacted, and yourselves, so we can provide information on things like what is there, like, so we have things called ZTAS pins, so it's like an ID basically for each patient.
So like their registration number.
A bit like the MRN that we have here, but a ZTAS version essentially. So we can give you that information. We can tell you how often they need to have monitoring, when was their last test, when's the next one due, all of that sort of thing. But depending on, like I said, how often they're having it, so it might be, so for the first, I think it's 18 weeks.
That's right, yeah.
You have to have it every single week.
Yeah, so it's really quite frequent,
So it's really, really frequent, and it never goes away. So after that, for the next 52 weeks, up to 52 weeks of treatment. So once you've been on it for a year, you still have to have them every other week. And then after that, the absolute sort of minimum blood test you have is monthly.
Yes.
But even that is dependent on the results.
Yeah.
So I suppose from your perspective, how do you see, so with obviously we keep saying we're sending them to ZTAS, we're getting these results.
Yeah.
What are we actually getting back?
What are we getting back?
Yeah.
So I suppose you're looking at the full blood count, aren't you? And I think it's mostly that they look at the neutrophils and the white cell count, and I think some other parts of the neutrophil screen are important. But what you then get back from ZTAS is a kind of a traffic light system, so a kind of red, amber, green. And if someone has a green result, that means they're happy with their full blood count and they can carry on having their clozapine. If there's a red result, that means they're significantly worried about the white cell count and the patient's at risk, and they won't generally dispense the clozapine at that point. And you have to kind of rethink whether or not it's appropriate for that person. ZTAS actually do have medical officers and pharmacists themselves, so you can phone up and have a conversation with them. And that would usually be something that we would be expected to do in liaison, or in fact the community consultant who's in charge of the prescribing, perhaps. And then sort of amber results are where it's a bit borderline. The white blood cells are not doing what they were expecting. Perhaps there's a trend that's kind of going down. And then generally the patients are allowed to have the clozapine, but you have to have more monitoring again. So they might go back up to weekly or even more frequent blood tests where they've been not having them before.
Okay.
You can imagine in a hospital setting where people are poorly as well, that can have quite an impact on what's going on with their clozapine, and so you often have to do more frequent monitoring. In the community, when patients have their bloods done, they get sent straight to ZTAS because part of the kind of cost of the clozapine prescription is the monitoring and all the bits around it, isn't it? But they can also use the blood results that we're doing in the lab here.
Yes.
So you don't need to worry about sending bloods off elsewhere when the patient's in hospital. They can just be processed in the local lab.
Yeah, I think that's something that either the ward pharmacist, so any ward pharmacist at GRH or CGH should know how to, and if they can't themselves, should know how to contact either ourselves or you guys in terms of sending them off. So yeah, they do not need extra bloods.
No.
Don't be sticking them twice just for some extra clozapine.
And I think, in terms of sort of phoning results through to ZTAS and things, the pharmacists are often really helpful with that, aren't they? But it is something that the junior doctors on the ward could do.
Oh, absolutely.
If they wanted. Yeah. So, ZTAS is easy to find online, and you can Google it and find their phone number and phone results. So as long as you've got the patient's PIN number, you're able to do that, I think. Yeah,
and the other thing, so they can, if you haven't got the PIN number for whatever reason, say it's out of hours, pharmacy haven't seen the patient, or for whatever reason, ZTAS can take other information. So it might be an NHS number and a date of birth, or initials and NHS, something like that. So just because you don't have the PIN to hand, don't think that you can't do anything.
Find out anything.
Yeah, just give them a ring. They are really, really lovely. Whenever I've had to ring them.
They're really helpful, I think. And that, I've had good advice from the pharmacy team there and the doctors. And so, particularly we thought about, having to change or discontinue results if the patient's becoming very, very unwell, their end of life or something like that. Then, we don't want people to get psychotic when they're dying.
They're just,
but so we do think quite carefully about, times like that around clozapine prescription and things. Yeah. So apart from the kind of white cell count problems, clozapine, like we said, has got a whole host of other side effects, hasn't it? Do you want to sort of run through a few of them?
Yeah, so one of the most common ones that patients, particularly when they're newly started on clozapine, will complain about is things like sedation. So like with some of the other antipsychotics, it can unfortunately make you quite sedated. So that might be, some patients will take it twice a day, but that might get moved to all at night to try and combat that. Hypersalivation is another one, so they might complain that they're drooling, particularly in the night again, so they wake up and their pillow's wet. There's a couple of non-pharmacological and pharmacological treatments that we can sort of input for that.
Yeah.
But I think the main one to mention with clozapine, unfortunately, is constipation.
Yes, I think that's the big one, isn't it?
And I think that's the thing that we all see constipation day in, day out. Everyone's been constipated at some point. No one thinks of it as this really horrible thing.
Yeah.
But unfortunately, with clozapine patients, because of the nature of the clozapine, it can cause sort of fecal loading, impaction, and there have been a decent number actually of fatalities from constipation. So constipation in clozapine is something that's really, really important to monitor. Unfortunately, clozapine patients will be very used to asking about their bowel habits.
Yes.
We ask them all the time in clozapine clinics.
Yeah.
We've, I think, been coined the term poo police at various points. Just asking the patient, when was the last time you opened your bowels? You know, making sure while they're in hospital you're keeping a stool chart, how often, what type, that sort of thing. And if there are any concerns at all, escalating it to yourselves as a matter of urgency, really, with clozapine. But I think you'd agree, just because someone's constipated or experiencing side effects, it's not a reason to just...
No, so I think there's a few other important bits to think about clozapine, isn't it? So sort of three off the top of my head, and the very first one is to really try to not make any changes to it unless it's absolutely necessary. And if you do have to make changes, you need to be discussing with the mental health teams, because the hospital are kind of, they're prescribing it in lieu, but the actual designated prescribers remain the mental health teams, either myself or my colleagues or our community colleagues. And so kind of any changes sort of need to be run by us, really.
Yeah.
I think that the second one that I had in my head sort of goes alongside that, and that's the kind of 48-hour rule for the clozapine.
Yes.
Yeah. So that's if clozapine has been stopped for a period of 48 hours for whatever reason, say they've come into hospital and somebody didn't know that they were taking clozapine, for instance. We've had a few of those in the past few years. The patient actually has to be retitrated onto their clozapine and go through the whole process of repeated blood tests, and it can leave them in a sort of window where they're not receiving their optimum treatment, which is can mean a whole variety of nasty things for the patient, but also quite a lot of resources for the NHS in terms of mental health crisis teams needing to be involved, or even patients having to come into mental health hospitals to have their treatment sorted out again. So I think that picking up that the patient might be on clozapine bit right at the start of their hospital admission is so important.
Absolutely, yeah. And I think that's something that I've had calls before, like as an on-call pharmacist overnight. If there are concerns that they've missed a dose, feel free to give the on-call pharmacist or yourselves a bit, like there will be someone that can help.
Yes, it's one of those ones that on-call pharmacists probably really don't mind coming in to sort out.
I'd 100% much rather someone rang me and it was completely unnecessary, they can have the dose and it's absolutely fine, rather than taking the risk and either omitting the dose because you're not sure, which can be just as detrimental as giving a dose that you probably ought not have given. So
quite tricky. I suppose that the last thing that popped into my mind about clozapine in the hospital is smoking and clozapine.
Yes. So smoking is an interesting one. So smoking does affect, unfortunately, the levels of clozapine that are essentially free in your blood because of how it affects liver enzymes. So the more that you smoke, the higher the dose you'll need. And obviously being an NHS site, we're a non-smoking site. So a lot of our patients will be given NRT or asked just not to smoke or something. So absolutely, like you said, it's really important to be aware that these patients might actually need to be monitored, and being aware of some of the more toxic effects of clozapine. So if they suddenly stop smoking and they've got this massive dose of clozapine that they probably don't need anymore. Whilst I'm absolutely not advocating to drop it without any consultation with yourselves, we can run levels. So clozapine assays, they're not an immediate thing. It's not like with gentamicin where it comes back a couple of hours later, but it is something that we can monitor, and monitoring the patient for those symptoms of toxicity. So you're thinking about, like, are they getting particularly tachycardic and short of breath and all this sort of thing. Again, it's something that if there's a patient on clozapine, I imagine you guys are always involved.
We should always be, so we would expect to be contacted by the ward, definitely.
And it's something that I think the tobacco team may not necessarily pick up on because it's not something that they necessarily have to. But clozapine isn't even the only one, so other medications like theophylline and things are affected by smoking as well. So it is really important if your patient is usually a heavy smoker or usually even just smokes a couple a day.
Yes.
That is considered if they're suddenly not smoking or we've changed them to vapes and things like
Yeah,
that.
and it's sort of an unintended consequences thing, isn't it?
Yeah.
You know, we're trying to benefit their health, but
Yes.
it's changed what they're normally doing, and it makes a bit of a difference.
Yes.
I think I know that the tobacco-free teams up at Wootton Lawn and Charlton Lane are very kind of au fait with it, but like you say, I'm not so sure about the hospital teams, although I do know one of our very lovely community mental health nurses came in when they set up the tobacco-free team over here and was working for them, so maybe she's educated everybody.
Maybe they'll be better than us.
Yeah. With the assays, they can't be run locally, can they? I think so. I think that you have to speak to us because you have to get GHC to process the assay.
Yes, it's unfortunately not the easiest, and it wouldn't show up on, because it's not processed locally, it wouldn't then show up on the Sunrise Bloods.
Yeah.
But again, yourselves or the mental health pharmacy team can
we can
liaise
help you
with
sort
the
it
labs
out
and get you the level that you need.
Yeah. So we talked a bit about what if the patient misses their clozapine, didn't we? And you know, the sort of 48-hour rule and things. I think that, you know, those bits and the smoking are the kind of bits that I really want people to pick up on. And and you know, like we said, please just always call us and ask for advice. Really. How would, you know, we sort of said it might get missed off of Dewey and other things like that. How would somebody know about clozapine?
Yeah, so like you mentioned, so clozapine is, if it's used in schizophrenia and psychosis, it's treatment resistant. So it may be that you've got one of those cases we sort of touched on earlier where there's a patient, they have a history of schizophrenia or something similar, but they're not treated with anything. So that can be sort of like your first warning sign of, oh, I might need to dig a little bit deeper than just a quick Dewey search. If it's not on the GP records for whatever reason, if there is any concern at all, having a chat with yourselves, asking the patient again.
Yeah,
these patients
the patients usually know, don't they?
They're having to have regular bloods and clozapine clinics and all these sorts of things. They'll at least be able to tell you that they take it. As a very basic. They may not know necessarily the dose, but they'll at least be able to tell you that they take it. And who they usually see for it or where it usually comes from. So it might be that they collect it from Cheltenham General. It might be that their care coordinator comes out and delivers it to them, in which case have a chat with the care coordinator. You know, we obviously yourselves can help with that. We can help with that with the mental health pharmacy team, but there are quite a lot of different places you can go digging.
You can find out that information. Yeah. Okay.
So I think that's
the most of the stuff that we wanted to talk about clozapine.
Yes.
We could potentially, couldn't we, make sure that there's Aponex numbers around on the intranet and things like that. So we'll make sure we get 100%. That onto our mental health webpage. And obviously, hopefully people already know our contact details in pharmacy and mental health liaison. But perhaps we'll do a slide that goes along with this or something.
Absolutely.
Yeah. So I think we've covered enough about antipsychotics for now. Let's talk about something different.
Have a little bit of a change.
Yes. I think the other one, the really big one that I want people not to miss when patients come into hospital is lithium. I think we should start with lithium and then we'll talk about some of the other things later. Okay, yeah. So, I mean, the first thing I think of when I hear lithium is the periodic table. Yes.
An element. Obviously, it's a medication as well.
So I mean, yes, like you say, it is an element, isn't it? We don't really understand exactly how lithium works in the medication, actually, but it is a very effective medication. It's prescribed like as a salt, so either lithium carbonate or lithium citrate. And there are quite a few different brand names for lithium, but I think the two most common ones that you might come across would be Priadel or Camcolit. So those are the ones that I think most prescribed. And I guess, you know, one of the first things when we're thinking about brand names is a bit like with the clozapine. It is usually wise to prescribe somebody their lithium by the brand name, isn't it?
Absolutely.
Because the different sort of forms have quite different formulations and bioavailability and things, and so patients can respond quite differently to those different forms, can't they? So I probably should say a little bit about what lithium is used for.
Yes.
Yep. So it's really one of the most effective mood stabilisers that we have. So it's most often used to treat bipolar affective disorder. And it's probably the best mood stabiliser, like I say, because unlike many of the other medications we use, it can be used in bipolar disorder to treat the manic episodes, the depressive episodes, and to keep people stable in between times. And there aren't many of the other medications that have got a good evidence base for that. it's also sometimes used to kind of augment antidepressant treatment in somebody who's got a difficult to treat depression. So although it's most commonly used for bipolar disorder, not everybody who's on lithium will have had bipolar episodes. So that is worth trying to kind of unpick and pin down, because that can make a difference to sometimes the importance of its ongoing treatment. So particularly if somebody's very poorly and you're using it to augment their antidepressant, it might be perhaps slightly less important to try continuing it. Whereas if you're using it as a mood stabiliser for that bipolar disorder, you probably want to try and do everything you can to keep it going.
Yeah, absolutely.
So I suppose why are we talking about it? What do we worry about when we see people in the hospital?
So I think lithium is one of those ones, like you said, so it's really, really effective, which means actually it's not uncommon that we use it. So it is one that I think the majority of people will see come across in various patients at various times. But whilst lithium is really, really effective, unfortunately it's also got some really nasty side effects and an incredibly narrow therapeutic index. So lithium levels are something that we monitor quite closely. That's definitely something we need to be aware of. In terms of other things we need to be monitoring, like renal function and things. So if you've got a patient that's got really nasty AKI, getting in touch with yourselves and finding out, okay, what are we doing about this lithium? Is it safe to continue at this point? Like you mentioned, finding out why they're actually on it to start with is really helpful in making that decision. In terms of the actual levels that we're looking at, we sort of think about between 0.4 and up to 1 is about, that should be where a patient sits. But as soon as you go over 1, actually you could be entering toxic.
Yes, so that's what you mean by the narrow therapeutic window. Basically that bit that we want them in for kind of treatment response is really close to the point where they can be toxic, isn't it? So somebody might run levels to sort of maintain their treatment at sort of 0.8, 0.9, and it doesn't take much to tip them into that sort of toxic zone.
So we're talking about toxic and sort of like the adverse effects and things. What do you typically see with these patients?
So I suppose thinking about toxicity, it's got a whole variety of different sort of things that you might spot. I suppose you mentioned renal function. We know that lithium is not very good for people's kidneys anyway, and it gets metabolised entirely through their kidneys. So it's very sensitive to, if their renal function goes a bit wrong, or particularly if they've been started on other medications, particularly sort of blood pressure medications, or if they're a bit dehydrated. And then the bits that you might start to spot when they're kind of going into that toxic level, a whole variety of different things to look out for. So diarrhea, vomiting, their appetite might go off, feel a bit sort of dizzy or weak. They can become a bit uncoordinated, as, if you're sort of heading more into the danger zone, sort of uncoordination, blurred vision. People can get quite a coarse tremor, particularly kind of your jaw and your hands. You can develop a kind of tremor in your jaw. And then people can go on to, have sort of drowsiness, coma, even death, unfortunately, if we don't spot it soon enough.
So it can be really nasty.
It can be really, it's very dangerous. So I think the importance of doing some of these lithium levels, if they come in on lithium, people can often get a bit worried about doing lithium levels because, to give us a kind of accurate view of their sort of treatment response, we like to have 12-hour post-dose levels, don't we? Because that gives us, a good view of what the lithium is doing in their body and helps us understand it. But if someone's come in poorly, I probably don't really care whether it's 12 hours post-dose. I just want to know whether some of their physical symptoms that they're getting are down to the lithium or down to something else. So particularly... And you can get a kind of a bit of a vicious circle, can't you? So somebody might have had a gastrointestinal, virus or something, and they've had a bit of diarrhea and vomiting. Then they've got a bit dehydrated, and they're on their lithium, and then the diarrhea and vomiting can actually then be the lithium toxicity that's ongoing, and so you can sort of mistake things and miss it really easily. So I think just if you have anybody who comes in on lithium, they should be getting levels in the emergency department as kind of part of their workup. What about the kind of longer term side effects of the lithium?
So, like we mentioned, lithium unfortunately is a nephrotoxic, so it does long term cause kidney damage. Whether that's an acute thing, sort of with an AKI, or whether that's a more chronic, unfortunately, it does happen. So it is something that, urine and sort of the UNEs we monitor quite closely, and we do monitor regularly. Other things that might start causing things like thyroid or parathyroid problems. So checking the thyroid function again. Is it an urgent one when someone first comes in? Probably not. But
one not to forget.
It's worth checking while you've got them there. If you're doing some bloods anyway, there's no harm to add on a couple of extra tests. And the other thing it can cause, unfortunately, is things like diabetes insipidus when you've got that really like dilute urine. So there are a couple of longer term issues with lithium. But again, like you said, it's really, really effective. So it's that risk benefit discussion, and that's absolutely not something that we would expect juniors to be having or doing.
No, so we would never expect decisions about stopping lithium, except if you're holding it for a brief period because the patient's toxic. So the longer term decisions about whether to start or stop the lithium should always be sitting with the mental health teams.
Absolutely.
I think it's quite interesting because lithium is such an effective medication. Sometimes you see people who've been on it in the community for many, many years, very stable with their mental health, and they're no longer under any mental health teams. So that's quite a common scenario that I've come across in the hospital, is that because the person's been well for such a long time, because the lithium is such a good drug, then, you know, as they get a bit older, it might start to cause some kidney problems or thyroid problems. And then when you come in, you know, to start having think about what you do with the lithium. So mental health liaison are obviously the first port of call if somebody hasn't got a community mental health team. And, you know, we're always happy to give advice about lithium. I think the other bit about the not stopping and starting that's quite interesting is there's quite good evidence that each time somebody discontinues their lithium, the chances of it being effective for management of their bipolar disorder reduces.
Yes.
Again, we don't really understand why that happens, but there's really good evidence about that. So not stopping and starting lithium is really helpful for people's mental health. And so, you know, quite often if somebody's on lithium in hospital, I might ask for very regular monitoring, you know, just whilst they're poorly, so that I can try and keep them at a normal level and maintain their mental health as best as we can.
Yeah, absolutely.
So are there any other things that you think we should talk about? We're whizzing through psychotropic drugs at an absolute rate, aren't we?
I think that's lithium sort of in a nutshell.
Yeah.
I think one of the other important ones that, again, is probably one of the most common ones we'll see are things like antidepressants. So if we just sort of
another list. I love a list.
Another list.
Yeah,
absolutely.
So, commonly prescribed antidepressants. I mean, many antidepressants are actually prescribed by GPs, and patients who are taking them might not be under mental health teams, particularly if they're on the kind of most commonly prescribed ones. So those would be SSRI medications usually. So that stands for selective serotonin reuptake inhibitor.
Yeah.
And the way those work in a sort of, you know, brief form is to boost the amounts of serotonin in your brain.
Yes.
So common examples: fluoxetine, sertraline, citalopram, escitalopram. I think those are probably the most common ones of those.
Yeah.
There are some other ones that are more prescribed in other parts of the world. So sometimes if you've got people coming from elsewhere, you might see some other ones. But those are the sort of typical UK ones. And then there are a few other sort of really commonly prescribed antidepressants that you might come across that don't fall in that SSRI group. I think the first one that comes to mind is mirtazapine. So that is from an antidepressant group called NASA's. Nothing to do with space at all, sadly. It sounds very futuristic, doesn't it? But that stands for noradrenergic and specific serotonergic antidepressants. So they work on noradrenaline as well as serotonin. And then the other one, which is prescribed really frequently, but often not for depression, more often for, or even not by a psychiatrist at all, usually is amitriptyline, which you see a whole bunch of patients on for a variety of different reasons. So amitriptyline is pretty much the original antidepressant, isn't it? It's the first one that was sort of marketed for depression in the 1950s. And so it's a very old one with a lot of side effects.
Absolutely.
Which is why psychiatrists tend not to use it that much anymore, actually, because the sort of doses that we might want to prescribe it at for depression are quite high and tend to cause lots of other side effects.
Yes.
But it's very much beloved by GPs because it's quite sedating, so it's often prescribed for sleep, and it's also quite often used for kind of nerve-related type of pain or sort of GI nerve pain as well.
But at much lower doses.
Yeah, much lower doses, so we're talking kind of 10, 20, 30, aren't we, for that, whereas the kind of doses that a psychiatrist might try and use for depression are higher, sort of 150 kind of type of doses.
Absolutely.
So there are some other tricyclics that you might come across, nortriptyline and imipramine, but amitriptyline's by far the most common of those. Yeah. So why we worry about seeing people on antidepressants in a hospital?
So, like with any of the other meds we've discussed, like with every medicine on earth, I suppose, they do unfortunately work, but they also come with other unfortunate sort of adverse effects. So if you're adding it into something that is already, if you're adding in medications that can prolong the QT, some antidepressants will also prolong your QT. We would usually advise, if you've got 2 or more QT prolonging medications, you at least want an ECG. You want to know a baseline. Can you use something else? Do you have to use whatever antibiotic it is you've added in, your quinolone or a macrolide? Could you use something else that has lower risk? There's also, with SSRIs in particular, unfortunately because of how they work, they do also increase your bleeding risk. So it's something to be aware of if you've got a patient who's particularly high risk of bleeding that's also prescribed their VT prophylaxis and their ibuprofen for pain and all these other things.
And some aspirin. And
a little bit of aspirin, just all of it together could unfortunately cause a problem. Commonly with SSRIs, it's gastric bleeding, so something to be aware of. GI bleeds are unfortunately not uncommon. Some of the other things we talk about, so with SSRIs again, they are known as a potential cause of hyponatremia. So I think we all potentially get a bit trigger happy when a patient has hyponatremia with immediately saying, it's a drug cause, stop any drug that could be doing it. And actually taking a step back and thinking, well, is there something else that might be going on? If a patient's been on it for a long time, there's quite a lot of evidence now that's saying if SSRI in particular is going to cause hyponatremia, it's usually in the first couple of weeks of them having it. But if they've been on it and stable for years with no issues, it'd be unlikely. I'm not saying it's impossible. No. But it would be unlikely. So just
but it is
going a bit gung-ho and
stopping something that might be keeping their mental health stable is, it's always something to consider, isn't it?
Absolutely. And I think with with all medications really, but particularly with psychotropic medications, immediately stopping often does a little more harm than good. So things like withdrawal effects are very definitive issues. So if you've got a patient that's on 200 milligrams of sertraline, going from that to nothing is potentially going to cause some real problems and withdrawal effects that will worsen the patient in the immediate, as well as worsen them longer term with their mental health. So again, having that sort of
there's one of the brilliant mental health pharmacists at the Maudsley, which is a sort of centre of excellence for psychiatry, who's coined this this term that she described, says that doctors fall into, which is psychotropic syndrome. Which is where there's a tendency to kind of blame everything on the psychotropic medications. And like we said, many of them have got very nasty side effects, and for that reason we do lots of different monitoring and other things like that. But I think psychiatrists actually tend to get really worried about these things, perhaps even more so than many of our kind of colleagues who prescribe medications for physical health, perhaps because we're a bit less familiar with some of the physical health things on the whole. And so I think actually there's a bit of a tendency to blame the medications, isn't there? And that's the psychotropic syndrome. It's blaming the psychotropic medication when there's, often an antibiotic or a whole load of other things that might be kind of contributing to the problem that you're seeing. So try to avoid the psychotropic syndrome, and we'll have got something good out of today's teaching session.
Absolutely.
I think. Yeah. So
that was a lot of information.
It was a bit of an information dump, wasn't it? I mean, I think hopefully, you'll have picked up some important tips from today. Remember about your lithium and the clozapine if you're seeing patients on them, and then just be thinking more about the other medications. But I suppose the biggest thing that was the takeaway is that you can always speak to us, isn't it, Izzy?
Absolutely. I think it's so easy now with extensions and bleeps. There's always somebody that you can speak to, no matter the day or night, whether that's yourselves in liaison or us in the mental health pharmacy. On-call pharmacists all have mental health training to some extent.
Yes.
So we will make sure they have access to the systems even if they're not full-time mental health pharmacists. So having that courage to make the first call. The first time I rang you guys, I was like, hello, please don't shout at me, I don't know what to do.
We're very unscary, aren't we,
Absolutely.
at mental health liaison? We're always happy to kind of chat through things, if it's going to make life better for the patient.
Yeah,
so,
and
give us a shout.
It's not a formal referral. We're not asking, they don't have to ask you to come and see the patient and do this whole workup. It could just be a case of, this is what we've got, this is what I'm thinking. what, you know.
Yeah, what do you think?
Yeah,
yeah.
How does that sit with you guys? And I think it's really important for people to remember.
Yeah. So our extension is 5490. And there's somebody on the end of that extension or the bleep that's also on that phone number 24/7. So, you know, even if the person who picks up the phone, like I said, is a social worker and can't give you an immediate answer, they'll be able to help you find someone who can. So,
absolutely. Yeah. So we've got various different pharmacy options. So the typical one people will ring is 5509. We'll get you through to GRH pharmacy in general. If they can't help you, they'll put you straight through to us anyway. They may just tell you to ring us. So we're often found on 6829, but all of these numbers I'm sure we can put out with a little slide or something, so people don't have to be manically finding a pen right now and writing it
down. But so well, thank you very much, Izzy.
Thank you so much.
It's been an absolute whistle-stop tour of mental health drugs, but hopefully we've covered the important bits.